Hello, this is Robert McMullen. I'm a psychiatrist who's been doing mainly psychopharmacology and now TMS, transcranial magnetic stimulation, for over 30 years. Although the TMS I've just been doing about 8 years and only came on the market as being FDA approved 10 years ago. Now, I went to Georgetown Medical School and Columbia for my psychiatric residency. I want to talk about two things: premenstrual problems, PMS and PMDD, and menopausal problems. Now first, the premenstrual problems. PMS is what most people hear of, and that's having mild depression before the menstrual period, lasting a few days or up to a week, and it usually ends with the menstrual period starting, or maybe a little after. And it doesn't usually cause much dysfunction. Now, when the PMS is more severe, then we call it PMDD, which means premenstrual dysphoric disorder. And dysphoric just means feeling miserable. And then there's a certain number of symptoms you need on a list, but it mainly boils down to anxiety, irritability, and labile mood. And this disorder makes it very uncomfortable for your significant other and any other people you're living with, because you're just more angry, irritable, and get irritated by little things that wouldn't bother you normally. And in some cases, I've known people who had really severe fights, and then after a while, somebody, the husband or the patient themselves, realized it always happened right before the menstrual period. Now, the way you can manage this, the primary ways of managing it, is to take a serotonergic antidepressant like Zoloft, Prozac, Celexa, Lexapro, and so on, or to use oral contraceptives. Sometimes with the oral contraceptives, you have to experiment and try different ones to work. Now, a third thing is to use calcium. And this was first noted some years ago, where they did a double-blind study, and the women taking about 1,000, 1,500 milligrams of calcium per day had significantly less premenstrual symptoms, and then they did a crossover where the people on a placebo then got the real medicine, and it was consistent. Now, some of the women couldn't tell the difference exactly because PMDD and PMS vary so much from month to month. But the fact is, on average, taking the calcium really lowers the symptoms, and there's been another study or more recently that confirmed this. Now, you should only take this calcium for a short period of time, either after the PMDD starts, or you can calculate a day or two early. Because if you take high doses of calcium all month long, it really raises the long-term risk of heart attacks. Now, one of the problems with the oral contraceptives is that if there's much progestin in it, a progesterone type hormone, that really increases the amount of depression. So the hormone replacement brands that contain drospirenone, D-R-O-S-P-I-R-E-N-O-N-E, like Lorena, Yasmin, and Yaz, they often are of significant benefit. But they shouldn't be used if people are over 35 or who smoke, because it raises the risk of thrombotic events. And the effect size of changing these oral contraceptives is sometimes modest. So sometimes you need it with the serotonergic antidepressant. One other thing is leuprolide, and this is something that completely blocks all your hormones, and then you're not cycling anymore. However, I had a patient a long time ago, and the gynecologist warned me that it wouldn't work. And he was right. We stopped all her hormones. She didn't have any of the female hormones cycling at all, but her depression continued to cycle. And some people in menopause find the same thing. The hormones are flat, but they're continuing to cycle every month or so. And that occurs. But sometimes blocking everything will help. Another thing is to use these non-pharmacological behavioral changes to help PMS and PMDD. One is to exercise a lot, a huge amount. And then calcium, like I said, and also bright light therapy, where you get under a very bright light box like you treat seasonal depression, but you have to be close, like a foot away. Or if it's springtime or summer, you could just go outside for half an hour and let the bright light be up there. You don't have to be right in the sun, but don't sit next to a building or something. And a low-fat vegetarian diet, that helps. Another thing you could do is use Seasonal or one of the other ones, or just any birth control pill, but use it continuously so you only have a menstrual period 4 times a year. And in conjunction with your gynecologist, you could do this. So if you have really severe PMDD that is just torture to go through it, then if you only have to go through it 4 times a year instead of 12 is a big difference. Now, switching to menopause. In perimenopause, the time just before and around and after, and there's really an increase in depressive symptoms and an increase in new onset depression occurring in people who've never had it. Also, for the first 5 years after menopause, a woman is much more at risk of depression than at other times. So there's much more risk of having 1 depression or 2 or 3 in the first 5 years after menopause than there is in the next 5 years. So that's a period where you just may have to do more things to help control this depression. And it's likely has to do with estrogen going down and being low. Now, during this time, you also should rule out sleep apnea, which often looks like depression and maybe exacerbates depression. And it's more common as you get older, if you're overweight, if you've been smoking, and it's more common after menopause. And that you need a sleep study for, but a lot of people have that and are not heavy, and they don't look like candidates for it. One hint is if your significant other or someone else in the family hears you snoring a lot, then that is an indication you might have sleep apnea. One patient who was about 40 who I had who came out of lifelong depression but still felt tired all the time. I finally sent her to have a sleep study, and it turned out she had restless leg syndrome, which is fairly common. But her legs didn't move. See, so her husband didn't notice it. She didn't have the sheets all moved around, but they just barely moved. And on the electrical monitoring they did on her, they could see this really significant electrical discharge having to do with the muscles that really interrupted sleep. And once she took medication for that, that really improved. Now, how to manage hot flashes in menopause. The main things are using estrogen, gabapentin, paroxetine, which is Paxil, and venlafaxine, which is also called Effexor. And these significantly decrease the hot flashes. The gabapentin the brand name of which was Neurontin, is something of a surprise. It was first came out as an anti-seizure medication and is widely used for anxiety, for pain, as well as for epilepsy. It seems to have quite a good effect on hot flashes, and it's a very tolerable medication that you can go up slowly on, and the only side effect is sedation, but that goes away if you go up slowly. It's also extremely safe, and you cannot even get allergic to it because it is an amino acid and it's too small to have an allergy to it. Now, the various things you can use for these for the menopausal depression is estrogen, and there's some studies with this, and it does improve the mood in women with major depression, but it's not always dramatic, and there are other risks with estrogen in menopause. Another common treatment is serotonergic antidepressants. And these very significantly treat the hot flashes and also benefit the depression at the same time. If you use a medication that's not serotonergic, like Wellbutrin, which is bupropion, it has no benefit for hot flashes at all. It has to be a serotonin medication. Now, there's some integrative treatments that are advocated, like black cohosh and soy. But in a large study, there was no benefit compared to estrogen. The black cohosh and the soy did the same as placebo. Only the estrogen did significantly better than placebo. Another thing is Epa Eicosapentaenoic Acid. This is an omega-3 fatty acid from fish. And just remembered by EPA is like Environmental Protection Agency. There's another omega-3 in fish oil called DHA. But EPA is the main one that helps depression, and it also helps decrease hot flashes. So if you have hot flashes and depression, this is really important to take. And most of the literature says take 2 or 3 grams of the EPA. So if you got only 500-gram pills of pure EPA, that would mean you would have to take 4 to 6. It's a little less expensive to get a 1-gram pill, which is usually not pure EPA. But those are fine too. In my experience, taking higher doses is often better. Now, another thing to take is, for hot flashes, as I said, are the SSRIs and gabapentin. And many women are on tamoxifen because 1 out of 6 American women get breast cancer, and they're using this as maintenance to prevent it from coming back. Now, the antidepressant that is the safest with this is Effexor, venlafaxine, because there's no drug interaction. Anyway, that's the information I have to impart on premenstrual and menopausal disorders. And also, if you're very depressed and these things don't work, then you should go in for TMS, Transcranial Magnetic Stimulation, which has virtually no side effects. And sometimes it's a little uncomfortable because the scalp muscles tighten up. But, of course, if it's getting uncomfortable, then you just say so, and we cut it down and stay lower. And then after a few treatments, the scalp muscles accommodate and you can go up. But that's also always a great treatment for depression And then the best maintenance treatment after TMS really seems to be very tiny doses of lithium and lamictal or lamotrigine. And these have practically no side effects in the doses used. In any case, everyone approaching 60 should probably be on lithium because the evidence is overwhelming that it prevents Alzheimer's. You only need 5 milligrams once or twice a week, probably, but if you're prone to depression, you probably should take a 150 milligram pill every day. And that's something everybody should look into, and a lot of physicians are taking it now. Thank you very much.
Thank you very much, Doctor.